a preparation, an opportunity will be given so that you can raise your hand and ask a question. For our consultants on the call, you'll be promoted to panelists, and if there are any comments you have after this presentation, you can make it. Thank you for joining us, and you can share the link in other doctor platforms or on other doctor platforms so others can join. Dr. Pipra, please, you have the mic. Thank you.
Okay, thank you, Dr. Agbe. So, thank you for giving me the opportunity to present on chronic coronary syndrome. So, to start with, this is the leading cause of death worldwide. So, it's a condition that is of utmost importance to all of us. And the prevalence in our country is increasing. So it is something that we all need to be aware of and be able to manage the patients appropriately. Again, there are a lot of patients who present to our clinic with chest pain, and the chest pain could be as a result of several things. One of them is ischemic heart disease, which is a leading cause of death. So if a patient comes with chest pain, it becomes quite difficult trying to tease out which pathology is causing that chest pain. And I'm hoping that with this presentation, it will help us in evaluating these patients and knowing which ones are of cardiac origin and be able to manage these patients appropriately. It is important again to note, if the diagnosis is not done correctly, patients who have other conditions and not necessarily heart pain may be put on medicines that may not be beneficial and sometimes may be harmful. And in fact, in my clinic, I spend more time stopping patients who are put on treatment for coronary artery disease who don't really need it, because when you take the history makes it very clear that this patient has no cardiac problem, and I spend more time stopping the medicines rather than actually putting patients on these medicines. But again, if the patient has the condition and is not appropriately diagnosed, then they will go on and suffer the consequences, which is usually either a sudden death or probably they may come down with heart failure. And when I do echo, you see quite a lot of patients who have dilated hearts. They don't really have any hypertension, which is the leading cause of heart failure. And some of these patients might probably be having ischemic heart diseases, which were not appropriately diagnosed. So it's two-way thing. You may either diagnose somebody who don't have it, or somebody who is having the condition may go undiagnosed. So we're hoping that with this presentation, it will help us in evaluating patients who present with symptoms suggestive of ischemic heart disease. So my takeaway message is that chronic coronary syndrome diagnosis is never a pure yes or no determination. It is a probability-based assessment built on pretest likelihood, which uses risk factors, symptoms, and then imaging results. And even after the testing, which are the diagnostic testing, you may still have residual uncertainty. So the diagnosis is not a straightforward yes or no. Somebody comes with fever, you do your malaria test, it's positive, you think, oh, this one is malaria. But in chronic coronary syndrome, it may not be that straightforward. So you need to evaluate the patient wholly. You need to add a lot of things, clinical, your history, your examination, the patient's family history, and include certain tests to arrive at a clinical probability. And you say that the diagnosis is either low, very low, moderate, or high. And depending on where you put that patient or you stratify the patient, will inform you the necessary actions to take. Again, ischemic heart disease presents as either an acute form or a chronic form. And today, my emphasis is on the chronic presentation. The acute presentation is usually a plaque that ruptures and then a thrombus form. If it occludes the coronary artery, you may have a STEMI. If it's partial occlusion, you may have a non-STMI. But this one is a plaque that keeps growing. A thrombus usually does not form. And that is the one we are talking about today. So what is our roadmap? We have to make the definition and spectrum of the disease we are looking at. We're looking at a dynamic macro and microvascular model of ischemia. So we're talking about big vessel disease. The coronary arteries is made up of extracardiac vessels and intracardiac vessels, or macro vasculature and then the microvasculature. And diseases may occur in both, or you may evaluate the big vessels and you may not find any disease, but it does not mean that the small vessels do not have any disease. So in 50% of the time, the disease may be in the microvasculature, and these conditions also come under the chronic coronary syndrome. And then the diagnosis and risk assessment, as we said, is stepwise. You have to really evaluate the patient from your clinical history, your initial investigations before you make a pre-test probability, go on to do the test. And even after doing the test, you may do another post-test before you arrived at a final probability diagnosis and then decide what to do. And your treatment modalities are mainly medical, where you use anti-angina medications, or you can do revascularization. An important diagnosis, which usually involves the small vessels, is ANOCA and INOCA. And guidelines really recommend that we consider these conditions when we are evaluating patients with CCS. So this is the diagnostic to treatment flow in patients with chronic coronary syndrome. So the first step, a patient comes to us suggestive of having an ischemic heart disease. We have to take a very detailed history and examine these patients very well. After we have done our history and examination, then we go on to do what we call pre-test probability. So this pre-test probability, you can have a calculator where you input your history, your examination, and your initial testing. And when you put them in these calculators, they may give you values. If the value is less than 5%, then you stratify that patient as having very low pre-test probability. And if the pre-test probability is very low, you may not need to go on and do the diagnostic testing. The diagnostic testing are usually non-invasive testing. So if the pre-test probability is above 5%, say from 5% to 15%, then those are classified as being low. If it is low, then you may do what we call risk modification by doing mainly a simple test that can be done is a calcium score. Unfortunately, it's not so available everywhere and may not be affordable to most of our patients as well. But sorry, but it's cheaper than the main diagnostic testing. And sorry, it helps reclassifying these patients as to either being very low, moderate, or high risk. So when you do the pretest probability and it put these patients between 5 to 15%, you may do a calcium score to re-evaluate the patient. And then if it is more than 15%, then these patients have moderate probability. And for those with moderate or high risk probability, who are usually above 50%, these patients will need to undergo the diagnostic testing. The diagnostic testing we do mainly here under two categories. You either do the anatomical one, which is mainly a CT coronary angiogram, and or you may go ahead to do the functional testing, which is either a stress echo, and a stress nuclear test, or a stress MRI. The decision to do either an anatomical or functional testing again is based on your probability. If the probability is on the lower end, that is, if it is say moderate, is just above 15%, but below 50%, then in those categories, when the probability is not very high, it is recommended to do the anatomical testing, which is a CT coronary angiogram. But when the probability is very high, say above 50%, then doing the functional testing is recommended. The reason here is that when your probability is high, then the chances of having an obstructive disease increases. And if there is an obstructive disease from your pretest probability alone, then you may not need to confirm an obstruction, just an anatomical obstruction. You want to go ahead and do a functional testing to see if that obstruction is causing ischemia. And it's a functional testing that will help you to make a diagnosis of ischemia. So when the pretest probability is very high, the recommendation is to do a functional testing. And if the functional testing comes positive, then you would have confirmed your diagnosis. When you have done the diagnostic test, either an anatomical or a functional one, sometimes the conclusion may not be clear. So where you are having diagnosis that you are not sure, you may do the other one. So that is where we say you do a post-test probability. So usually what you do is that if you did an anatomical, you may go ahead and do the functional one or other way. And then once your diagnosis is made, you go ahead with your treatment. And your treatment is either your optimal medical treatment or doing a revascularization. So let me bring this calculator, which is online, which I think we can use in evaluating these patients. So when you go to Google, Dr. Albert, please, I hope you can still see my screen, right?
Yes, please.
Thank you. So when you Google RFCL calculator, so this is your coronary artery disease probability calculator. If you go to this site, Streamlit, you have a calculator there. When you click on it, you get this screen. And when you come here, all that we've talking about, they've put it into a calculator that you can use to get numbers that will help you in making up your mind as to what to do next. So let's go through. So you have your age here, you have the gender, and then you have your primary symptom. So in fact, in the 2019 guideline, we're using just these three in doing the pretest probability. But in the 2024 guideline, they have improved it by adding risk factors, because ischemic heart disease do not occur in a vacuum. It occurs in certain population of patients who have certain well-known traditional risk factors. And the previous pretest probability did not involve these risk factors, but the new guidelines add these risk factors, which helps in further stratifying these patients into either very low or low, moderate, or high risk, into these four categories of stratification. So if you look at the age, so this one has been, the age is anywhere from 18 to 100. So you can slide it to what your patient age is. So let's assume our patient is 50. You can leave it at 52. So our patient is 52. Is it male or female? If it's male, the probability increases. If it's female, the probability reduces. So you select one of it. And then when you come to the primary symptom that the patient is presenting with, it could be the angina equivalent. So the patient probably just has dyspnea on exertion. So that one, you choose the dyspnea. And then you have here shortness of breath and or trouble catching breath aggravated by physical exertion. If that one is there, you say it's positive. So you select it. If the patient is presenting with a chest pain, which usually they may come with, then that one you select the chest pain. And chest pain presentation, you look out for three main things. So the chest pain itself, is it substernal chest discomfort? And heart pain is usually substernal. So if a patient comes, the pain is on the right, it's on the left, it's on the back, these could be equivalent, but the classic presentation is a substernal chest discomfort. So if that is there, you select it. And is that chest pain brought on by exertion or stress? If patient says yes, you select this one. And is it relieved by rest or by nitroglycerin? If patient says yes, you select this one. So when all three are present, then this patient has what we call a typical angina. So he has all three characteristics being present. The chest pain is substernal, is brought on by exertion or stress, and is relieved by rest or nitroglycerin. This is the typical heart pain. So if all present, then you select all. If it's only two that is present, the thing changes from being a typical angina to atypical angina. These are old nomenclatures. They've been changed. But I mean, on this calculator, they still keep that one. So it changes to an atypical angina. And if it is only one that is present, then the classification is a non-angina chest pain. So if it's just one and it's non-angina, the probability reduces. So let's say a 52-year-old male presenting with chest pain has all three, then it's a typical angina. Then we add, so 2019 would have stopped here and given you your pre-test probability, and then you decide what to do. But the 2024 guideline help us by adding risk factors, which are important. The good thing is that when you add these risk factors, it's able to exclude patients who don't really need the diagnostic testing. Because somebody may come having no risk factors at all, but may test positive to these, your first initial assessment. And you may go ahead to do, say, a CT scan for this patient who may not need it. You might have wasted that patient's money. But if you add these risk factors, it helps you to reclassify these patients into those. In fact, it adds about 5% into the very low categories who may not need further testing. So if the patient has diabetes, you select. If there is current or past smoking, you select dyslipidemia, hypertension, or a family history of early coronary artery disease, you select. There is a write-up here that helps you to understand what each of these risk factors are. So if you are selecting diabetes, either the patient has type 1 or type 2, if it's on treatment or not on drugs but on diet control, it still qualifies as diabetes. Or if you've done a lab where the A1C is 6.5% or more, or the random is 11.1 or more. The past history of smoking is there, dyslipidemia cutoffs are there, hypertension definitions are there, and then family history of early coronary artery disease, the definitions are there to help you choose. So if it's first degree relative, the patient's mother, father, brothers or sisters, and if it's a man, should be below, the relative should have had this condition under 55. If it's female, should have been more than 65 years. So if that is positive, then you choose your family history of early coronary artery disease. So having done this risk factors evaluation, you get a score. So this patient's score based on what was positive in our history and initial testing. I mean, to get dyslipidemia, you should have done the lipid profile, and then you select it if it's positive based on the definitions that are down here for you. So your risk assessment for this patient comes to 24.3, and 24.3 is in the moderate category. So for this patient, you are going to go ahead to do your diagnostic testing. You have to go ahead and do your diagnostic testing because the probability is high. I mean, it's not the high one, but it's a moderate probability. Sometimes you may not get so clear probability. Let's take out these typical angina. When we do that, we see that our risk assessment has significantly dropped because the chest pain is not a typical chest pain. In fact, it's non-angina. So our risk has dropped to 5.8, and 5.8 is low. Very low is below 5. 5.8 is low. And if it is low, you may want to do a calcium score. So let's say you go ahead and you did your calcium score, and your calcium score comes as 0. Once the calcium score comes as 0, you input 0. And once you input 0 and you do your reassessment, let's have it. So you input 0. The calcium score of 0 reduces that risk. So it has actually dropped from 5.8 to 1.3%. It has dropped it by 4.5%. So you can safely say that this patient will not need the diagnostic testing, and then you may treat any risk factors he's having, or you may evaluate for other reasons for having the presentation. So the calcium score will help you in patients with very low or low probability of having the chronic coronary disease. But if your score was say 100, then the probability is going to increase. So if it is 100, let's evaluate it again. So if it is 100, it has increased from 5.8% to 15%. And this time it puts it into the moderate category. And once it increases, then you may want to go ahead and do the diagnostic testing for these patients. There are other things that you can include to even help you score these patients more. And it includes your clinical evaluation. You can do an echo, ECG, others, and you can input them into these calculators, and they may give you numbers that will help you make up your mind as to whether to go ahead to do the diagnostic testing. So I'll go back to my slides. So this is what I've spent my time doing, because in fact, in the clinic, this is what we should be doing for these patients. So when they come, we take our history, we examine, and then we do the pretest probability that we have just gone through. And once you have done the pretest probability, you score these patients, and based on your score, you may defer these diagnostic testing, or you may go ahead to do the diagnostic testing. The diagnostic testing, again, if the probability is on the lower end, then you go ahead with an anatomical testing. But if it's on the higher end, then it's good you test for ischemia, which is by doing the functional imaging. So what the burden, we don't have to overemphasize it. I mean, it is the leader when it comes to death. 1 in 20 adults worldwide live with coronary syndrome or chronic coronary syndrome. And an important note to this new guideline is that 50% of these patients may have no obstruction in the coronary arteries when they do angiography. Angiography, which is the traditional one, is the gold standard. And most of the time you go in and half of them may have clean vessels. But having a clean vessel does not mean that these patients do not have any disease. The disease may be in the microvasculature. So it is important that both vasculatures are evaluated, the epicardia and then the small microvascular disease. It's good to keep that in mind. So this is a picture of what we should be thinking when we are evaluating these patients. So the disease may be in the epicardial vessels, which is on the surface of the heart. I mean, let me go back. So these vessels, these are the epicardial vessels. That is what we see on the surface of the heart, and that is what our angiogram will see. When we put in a dye, we take fluoroscopies. So if there is a blockage by a plaque, they see it in these big vessels. But when we do it and it's normal, it's clean, it does not rule out the disease entirely, because the disease may be in the small vessels, which make up about 50% of the burden. So it could be either epicardia or it could be microvascular. And another thing is that it may not be anatomical. Epicardia, you may see a plaque in the vessel, but these epicardial vessels may be clean, but vessels be how do I put, vasospastic. So that is where the transmitter and the vessel undergo vasospasm, and it may also lead to cut off of blood supply, and the patient may present. So another pathology to keep in mind is vasospasm, which this condition present with. And then, as I keep saying, the microvascular vessels also needs to be evaluated. Aside being structural, they can also have a functional presentation. The epicardial one usually is atherosclerosis. So you may have a plaque there. Or it may be that there is no plaque, but it's a muscle that is going over the epicardial vessel. And that is myocardial bridging. Or it may be a plaque that has become calcific, or the vessel might have undergone dissection, or maybe patient has atrial fibrillation and might have thrown a clot into the coronary arteries. So these are other pathologies that can cause an obstruction in the epicardial vessels. So I put it in a mnemonic form to help us remember it easily. So A for atherosclerosis, the commonest one. B for bridging, muscle that crosses the vessel. C, calcification. D, dissection. E, embolism. And then you have your VAT here. It could also be vasculitis. It could be aneurysma, coronary artery, or it could be an in situ thrombus that forms. And thrombus will usually lead to an acute presentation. So that could be structural, or it could be functional. It could be functional, and that functional is the vasospasm. So you may not see any anatomical obstruction, but functionally, that vessel that looks clean may undergo vasospasm and lead to chronic coronary syndrome. And when you go to your invasive testing for these ones, you may have to induce vasospasm by giving them probably an intracoronary uh, uh, drugs like I think acetylcholine, and to try to see if you can induce vasospasm. And when you do that and the vessel undergo spasm, then you would have make the diagnosis of vasospasm. Making a diagnosis of vasospasm is important because the treatment is quite different from when you have a structural abnormality. If you have atherosclerosis, I mean, all of them you treat medically. But if there's a plaque is obstructing severely, say 90% or more, you may put in your stent. If there is bridging by a muscle causing damage, ischemia, chronic ischemia that is not going away, this patient will need surgery. If it's calcification, you may have to go and drill through that calcium. If it's dissection, again, you may put in a stent or something. If it's embolism, you may do embolectomy. If it's vasculitis, you may give your anti-inflammatory drugs. So depending on the pathology, you decide what to do. If it is vasospastic, there are medicines like calcium channel blockers that you give, and there are medicines like beta blockers that you avoid. So making the pathological diagnosis becomes important so that it will help you in deciding what to do for this patient. And then the microvascular ones, you may have arteriolar remodeling. Arteriolar remodeling, what happens is that The arterioles has smooth muscle. These smooth muscles may undergo hypertrophy. So the hypertrophy may cause obstruction in the arterioles, or it may undergo what we call eutrophy. Eutrophy, what happens is that it doesn't get big outwards. The size increases inward, so the lumen narrows, and this condition may also lead to arteriolar remodeling. Or you may have inflammation in the myocardium, fibrosis and other things that also narrows the arterioles, and this microvasculature can be diagnosed by doing, say, an MRI. You need microvascular imaging to be able to make this diagnosis. Unfortunately, some of these things are not available to us. Or you may have capillary rarefraction, which typically is where the capillaries just disappear. I mean, if they are not getting flow into them, the capillaries may die off, and the capillary density in the structure may reduce. So the capillary density in the myocardium will go down, and it's the capillary level that oxygenation occurs. So if the capillaries density reduces, then these patients are going to come down with ischemia. So the microvascular disease is quite important, and we always need to keep that in mind. The microvascular level too, the arterioles or the capillaries may be there, but you may have functional abnormalities, and these functional abnormalities may occur in the autonomic system, where you may have problem with nitrous oxide, so that the vessels undergo vasoconstriction, and or you have problem with vasodilatation. So that is the pathology that may be underlining these chronic coronary syndrome, and it's important these patients are evaluated. So with this, they will present with one of these 6 clinical scenarios. You may have gone to do a screening with, say, a test, and then they come with having a presentation. So they don't have symptoms. It's just your screening test that has picked it. Or they may be symptomatic presentation, and usually this is what we'll see in the clinic. They come in with chest pain or angina equivalent, and we need to evaluate them. Or you might have make a diagnosis and you want to follow them. The diagnosis might be a recent one or a long-standing one, which is over 1 year. This patient might have been revascularized, or the patient might come with either ANOCA or INOCA. And ANOCA or INOCA is actually the microvascular presentation that we've talked about. So ANOCA is angina with non-obstructive coronary artery disease. So the big vessels are clean, but they have a microvascular disease. Or INOCA, which is which is about the same. The difference between ANOCA and INOCA is mainly diagnosis. For ANOCA, which is ischemia, you have done testing which has proved that these patients have ischemia. So you have done functional testing which came positive for ischemia. For ANOCA, it's a suspicion. They have the symptom, but you have not really done the testing to prove ischemia. So they will be classified as having ANOCA. Or this patient might just come in with frank heart failure or LV dysfunction, say, on your echo. So we've gone through this stepwise approach to coronary syndrome diagnosis is very important. So I think I want to leave more time for discussion. Clinical assessments, I think we've done this. You take your history, you do your risk factor evaluation, your symptoms, you examine. Your examination is important. You have to examine the peripheral arteries. If flow in them is a problem, you can add them to your risk calculator, and it will help you in either classifying them upwards or downwards. And then as part of your initial evaluation, everybody should have a 12-lead ECG done. Mean they should have their basic biochemistries, their lipids, sugar, kidney function test, inflammatory markers like high sensitive CRP becomes useful. And all these patients should have a resting echocardiogram done to look at the ejection fraction and then the wall motion abnormality. Chest X-ray is in selected patients to look for either a heart failure or other cause of dyspnea, which may be pulmonary instead of cardiac. And then your age says, we've talked about these ones in your risk factor clinical model. 5% is very low, 5 to 15% is low, more than 15% is moderate, and if it is more than 50%, then it is high. If it is low, you may forget about doing the diagnostic testing. If it is very low, you can forget about doing the diagnostic testing. If it is low probability, then you add your calcium score, you put it in the calculator, and it will help you in reclassifying this patient. If it is moderate, then here you have to go ahead and do your your diagnostic testing. And your diagnostic testing, if it is moderate again, then the CT coronary angiogram is preferred. But if it is high, then this high probability, you don't want to just make a diagnosis of obstruction, but you want to make a diagnosis of ischemia. And it is important we understand this. Having an anatomical obstruction is not equal to having an ischemia. The obstruction may be there, but the patient may be having enough flow, so may not be having any ischemia. So when your pretest probability is very high, then your emphasis now is not to see whether it's obstructive or not, but your emphasis is to go furthermore to decide whether this obstruction is giving ischemia. So when your pretest probability is very high, you do your functional imaging to diagnose ischemia. And here the tests that you can do are your stress echo, your stress nuclear test, or your stress MRI. So we've talked about these ones: anatomical testing, functional testing. We talked about the role of coronary artery calcium score. Now, all along, I've not mentioned exercise ECG testing. And this is because it's no longer a first-line test to diagnose obstructive coronary artery disease. It's used when imaging is unavailable or to judge symptoms, exercise capacity, BP response, and arrhythmia. And it's helpful for assessing therapy and prognosis. So your exercise ECG testing is actually part of your initial the diagnostic test that you may do to reclassify this patient and to decide whether to go on to do an anatomical or a functional testing. So say you've done your pretest probability and the score is low, you can't do an exercise ECG. And if it's come positive, then you may go ahead to do either an anatomical testing or a functional testing. If your exercise ECG test is positivity is very strong, say at 1 minute, 2 minutes of exercise, patient come down with angina, then in that patient, you may want to do a functional testing because when you calculate maybe the do score, it may be very high. So you may just go ahead and do your functional testing. As if the patient is able to exercise for quite some time before the pain come, and you think it's positive, but the positivity is not that strong, then you may do an anatomical testing, which is your CT coronary angiogram. So your exercise testing now, ECG now helps you to also do your rate classification instead of being used primarily as a diagnostic test on its own. So estimate the likelihood, select which test to do, confirm your mechanisms, either a big vessel or is in the small vessel, and then treat. So treatment is medical. So medical, all patients should undergo this medical treatment. And in fact, I should say the first one is lifestyle, very important. And then you add your medicines. So to relieve symptoms, you have your anti-angina or ischemic drugs, and you titrate this to control the symptoms. So that is your goal, to treat the symptoms so that the patient will not have the chest pain or the tiredness on walking. So that is your goal. It's a treatment target. So you give drugs to help these patients get rid of this symptom. And your second goal is to make sure that the disease itself is treated. And I mean, uh, high cholesterol is a big on these diseases. So you need to intensify your lipid lowering treatment. We know of cardiometabolic agents. So these drugs too are useful in reducing the risk factors. And then again, lifestyle is important in treating this condition. So your anti-angina drugs, beta blocker, calcium channel blockers are your first line. So you start one of them or you start the two of them. If it's not controlling your symptoms, you may add your long-acting nitrates. And if it's also not helping, you may add your ranolizine, ivabradine, and corandil or trimetazidine. These are helpful in relieving symptoms. So you add them as the patient presents. If you are doing beta blocker and the pain is gone, you may not need to add the others. But if it's not going down, then you may go on to add more. If the patient has problem with blood pressure, say blood pressure is very low, then you may be careful in using these beta blocker plus calcium channel blocker. So you may just go straight to the second line drugs like ranolizine, ivabradine, trimetazidine to try to relieve the symptoms. If the patient's blood pressure is good or high, then you may want to do beta blocker plus calcium channel blocker because it will also help you in controlling the blood pressure. And then to reduce the risk of clots formation, you may put this patient on antiplatelets. I mean, you are thinking three ways. So you are reducing symptoms with these drugs, and then you are reducing the risk of clot formation with these drugs. So antiplatelets, you do aspirin or you can do clopidogrel. And then if you have done,
Mr. Pepper,
yes.
please, it's 8:25. We just have about 5 minutes. If we could
Oh, okay.
maybe, yes, please.
Okay.
Thank you.
Thank you very much. So you may do I think I'll stop here. Okay, let me just show them and then I move. So lipid lowering, if it's ischemic heart disease you are treating, your target is LDL less than 1.4. Here there is a disease. So you are not just treating the cholesterol reference range. Your target is below 1.4. You have a number that you want to go below. So you do your high intensity starting. If you don't reach this target, you add your ezetimibe. If you don't reach this target, you add your PCSK9 inhibitor. And then SGLT2 becomes useful in patients with type 2 diabetes or patients with heart failure. You may want to add these drugs. And then lifestyle prevention and adherence is very important. You need to control all these risk factors very well because that is what starts the disease in the first place. And then when to revascularize, you are treating these patients, giving all your drugs, there is no help. This patient still comes with pain, 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 pain. You may do revascularization, and the revascularization here is to relieve the symptoms, not to increase the lifespan of the patient, but just to relieve the symptoms. Sometimes you may revascularize and the symptoms may still be there. But if you keep coming with pain, 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 you can decide to go and put in a stent to relieve the symptoms. In certain situations, it does not just relieve symptoms, but it adds to your number of years. In that case, if the patient has a high risk anatomy, then that one is not just symptom relieving, it may increase the patient's lifespan as well. Okay, so the functional testing, I think we can read these ones later. Thank you. So I'll stop here.
Thank you very much, Dr. Pepper. So we'll take questions at this point. You can raise your hand if you have any questions and you'll be unmuted to speak. But we have one question in the question and answer box, and I'll read that. So this is from Dr. Bassi. He says, "Thank you, sir, for the lecture. How reliable is non-invasive CT coronary angiogram, I think with calcium score, in the diagnosis of chronic or even acute chronic coronary artery disease?"
So in all of these diagnostic testing, one thing you find is availability and then clinical expertise. So the reliability of the test is as important as the one giving you the reports. But mean in the right person is doing the reports, then it's very reliable. So once it's available and you have the experts giving you that report, then it is very. I'm a cardiologist, but I don't report CT coronary angiogram. So if I give you a CT coronary angiogram report, it may not be that reliable because I don't have the expertise in that. So the person giving you the report is very important and they are reliable. And again, you do your CT coronary angiogram for chronic coronary syndrome. You don't do it in acute coronary syndrome. In an acute presentation, that one is a different situation altogether. Unless you have stabilized that patient and you want to do reclassification, then you may do a CT coronary angiogram. In acute presentation, that one is a bit, the evaluation of those patients are a bit different because those ones you don't have time. Yeah.
All right. Thank you
So
very much.
it is reliable. It is reliable.
Okay. Michael, who has his hand up? So Michael, please, you've been unmuted. You can talk now. You can ask your question.
I think he's still muted.
So he can unmute. He's been allowed to speak, so he can unmute to talk. Michael, whilst we wait for him, we'll take contributions from our consultants. So we have Prof. Ejikum, Dr. Awendago and Ampofo on the call. So any contributions from our consultants?
Good morning. Not
Good
not
morning,
much
Prof.
from me, Dr. Pipra. Thank you very much for taking us through this. I think you took your time to do justice to it. So not much from me. I think chronic coronary syndrome has become very common here, and especially how to evaluate patients. Sometimes we tend to over-investigate some and also under-investigate some. So I'm very happy you took your time to delve into this aspect of it. And then the other thing people sometimes tend to not appreciate much is Minoka and Inoka. And recently, I'm seeing quite a number of them as well. Sometimes typical symptoms, you go and do the angiogram and it's clean. It does not mean that the person doesn't have chronic coronary syndrome or ischemic heart disease. So we should bear that in mind as well. Thank you very much.
Thank you, Prof.
Any comments from, okay, Dr. Bobie Safo is also on the call. Okay, there are no questions okay, there's a question in the chat box. Sorry, the question and answer. So the first one is, how do you request for coronary artery calcium score?
Okay, good. So you just write coronary artery calcium score. So you write it on, say, an X-ray forms. So query ischemic heart disease. Under the investigation, you put coronary artery calcium score. And then you send it to, you send the patient to the appropriate place where it is done. And they will do it for you.
Okay, thank you very much.
Sometimes people will just shorten it as CAC score, CAC score, but just as you put the coronary artery calcium score, you write it as such, and the test will come for you.
All right. So what duration distinguishes ACS from CCS?
So it's the presentation. So if somebody comes with an acute presentation, then it's ACS. And then if it is somebody who just walked to your clinic and then talk about pain that has been there for days or years, it's a CCS. So it is the presentation. It's not really days, but as to how that patient presents. And because the pathologies are a bit slightly different. In ACS, it's usually a clot. Say a plaque ruptures, a clot forms, and the patient start having severe chest pain. So it comes and then this severe pain that has just come on. That is ACS. Chronic coronary syndrome is pain. It comes when he exerts himself. When he rests, the pain goes away. He's been having it for some time, decides to walk to your consulting room. That may be a CCS. So it's actually as to the presentation and not really duration. So, and then a patient with chronic coronary syndrome may also present with ACS. So he's having his usual pain that comes on walking, say, 2 blocks. But then he realized that, in fact, walking just 1 block, he's having so much pain. That may be an unstable angina. So it's really about the presentation and is the history that will help us in deciding whether this is ACS or this is CCS. So ACS is the one you put on the ward, CCS is the one you ask, go and do this test and come.
Thank you very much, Dr. Pepper. We have a last question. Anonymous attendee says, great presentation. Please, what's the difference between ischemic heart disease and chronic coronary syndrome?
Okay, so I think I showed something in the beginning. So ischemic heart disease may present as an acute coronary syndrome or may present as a chronic coronary syndrome. So ischemic heart disease is like the big heading. So another word we use is coronary artery disease. It's a big thing, but under it may present acutely or it may present as a chronic syndrome. And it's the chronic syndrome type that we have discussed today.
All right. Thank you very much, Dr. Pepper. Those are all the questions we have. And let me just find, yes, those are all the questions we have for now. There are no hands up from the attendees, so I think the topic has been well understood. Are there any other questions or comments from any of our consultants before we end the call?
Thank you. I mean, just want to add something small that chronic coronary syndrome, just like acute coronary syndrome, is also a spectrum of disease. So in acute coronary syndrome, you have the three entities that may even overlap. In chronic coronary syndrome, similar things can happen. And indeed, there are people who may come without chest pain. The process of atherosclerosis and ischemia will lead to ischemic cardiomyopathy and other presentations. There again, people who develop acute coronary syndrome after the acute management also transition into what we call chronic coronary syndrome. So it's indeed a spectrum of disease as well. Thank you.
Thank you very much, Prof. Ejikun. Any further comments? Dr. Windago, Dr. Mponta, Dr. Ampofo, Dr. Dade, Dr. Abobiesafo.
Good evening, everyone. I said good evening, good morning, sorry. So thank you, Dr. Pepper, for the presentation. What I want to add is, in as much as we have the pretest probability scores, which can be underestimated for age, just want to draw attention that we are having quite a number of coronary artery disease with both chronic and acute coronary syndromes in young populations who do not have the typical risk factors. So yes, and as much as we use some of these pretest probability scores, we should always put the patient in context and always know about the other non-traditional risk factors that can influence your pathway. So that's a comment I want to say. And I want to say thank you to Dr. Pepper for this excellent presentation. Thank you.
Thank you very much, Dr. Ampofo. Okay, all right. It's 8:40. If there are no further comments, I think we'll bring our meeting to a close. So thank you very much, Dr. Pepper, for this very insightful presentation.
Thank you too.
Any final comments?
So final comment, I think these patients, evaluating them is very important, like Prof. Ejikun said. So it is very important they are well evaluated so that those who really need more testing, we do it for them. And those who don't need any further testing, we defer these testing. Because some of them, actually, just the history alone, the chest pain history alone, looking at the duration, the nature of the chest pain alone, you can say that no, you don't have any heart problem. So somebody come I have chest pain for 1 second, sharp breath comes like lightning and then it goes away. I mean, that alone may tell you that this is not a heart disease. So it's important that we take our time to take the history to help us in making in deciding how far we'll go with these patients. So clinical evaluation or doing the pre-testing is very important in evaluating these patients. Thank you very much.
Thank you,
Bye.
Dr. Papa. Thank you very much for making time for this presentation. So we'll bring our meeting to a close now. We'll continue with our GSC meetings next week. Thank you very much for everyone for joining, and then have a very lovely day. Bye-bye.
Bye-bye.